ask Dr. Shashank Shah to introduce the next speaker in the topic.
It's my pleasure to introduce Professor Osama Hamdi. He's a world expert and recognized thought leader in the area of obesity and nutrition in diabetes. Dr. Hamdi is a senior endocrinologist and medical director of the Joslin Obesity Clinical Program, director of the Inpatient Diabetes Program at Joslin Diabetes Center. He's also associate professor of medicine at Harvard Medical School. Plus his 34 years of extensive clinical experience. He is very active in nutrition and obesity clinical research. He has led to many innovations and discoveries that change how we currently manage obesity in patients with either type 2 or type 1 diabetes. Welcome, sir. Welcome for your presentation.
So thank you very much, Dr. Shah, for this generous introduction. And also thank you to Sanjay Agrawal and Dr. Anita Agrawal for inviting me to this wonderful seminar. And also I enjoyed the expert talks by my colleagues, Dr. Caroline Abovian, Dr. Judy Duche, Aaron Price, Jacqueline Shahar, and Sarah Holberg, and Dr. Samar Hafida. They are experts in their field, and they introduced a lot of wonderful information. My talk will be a little bit different this time, and we will be talking about obesity and diabetes from multidisciplinary clinical approach to digital intervention. So this is taking you a little bit to the future, how the future looks like. And it looks like COVID-19 made it an opportunity for all of us to try some of digital intervention. So diabetes technology is evolving significantly. In this year only, diabetes technology is around $23 billion. And it is expected in 5 or 6 years to reach more than $200 billion of business. This is very interesting and very important, how we will manage diabetes in the near future. So a couple of years ago, and before COVID, I published an article which was a very interesting article. The article was published in the famous Cell Metabolism journal, and the title of the article, Patient-Driven Diabetes Care of the Future in the Technology Era. And basically what I tried to do with Sahar Ashrafzada in this article is to expect how the ecosystem will work in the future, how we will treat diabetes in a different way in the future, how we will treat obesity, which is a core problem of diabetes in the future. So in this presentation, I will take you through some of the innovation that had been done and some which are in the pipeline for management of obesity and diabetes in the future. But let us, from the beginning, explain what we are talking about. Telehealth or telemedicine, and telemedicine similar to this seminar now, we are in Boston or in Indianapolis and communicating with you through this technology in India. So it's very interesting that the globe starts to be smaller through telemedicine. Mobile health is using a mobile phone and using mobile technology. I believe a lot of people now have not only one smartphone, but some people even have 2 smartphones or 2 lines on smartphone. And with G5 in the future, this will change dramatically how we use smartphone. So let us start with telemedicine. So back in 2019 and before the epidemic, we thought that the diabetes clinic will be reinvented. And actually, we have a publication which came a few months ago about this model called Jocelyn Home. And basically what we said is that diabetes care in the future will be reinvented. So this is a collaboration between Jocelyn Diabetes Center, which is leader in diabetes care for almost 120 years, and with American Well, one of the leading companies in telehealth in the United States. And basically what we thought of is to ship the clinic to our patients. So our patient at home, you give them a scale connected directly through cellular connection, not Bluetooth, no wire connection, just cellular. So when they stay on the scale, we have all the data, the same with blood pressure cuff, and also with a meter. And the meter again is connected to the cell. So when the patient checks their blood glucose, it is on our system. If the patient doesn't or didn't check the blood glucose, we know that the patient also didn't check blood glucose. We used web-based and then surrounded the patient with a group of providers. We have exercise physiologist, we have dietitian, we have Aaron Service, Aaron Price, who is a behavior therapist, and then the physicians and the nurse practitioners and the diabetes educator. And the whole idea here is to make all the clinic in the hand of our patients. So patients open their cell phone, they will have their own team. They can change the team if they like. They can look for the credential of everyone here in the team, and he can or she can swipe and change the provider and build their own team. They can click and make appointments directly with anyone in this team. But this is not the essence. We know that this can be easily done by computer software engineers. But what we try to do is to create a new 5 pillars of diabetes and obesity management. So number one, short visits, very, very small, tiny visits, could be 5 minutes, could be 15 minutes, could be even 1 single minute. So this is in contrary to what we do now, 30 minutes visits. I know in India, usually the visits are shorter, but it is multiple visits. So you can see your patients every week or every 2 weeks. And we put in the hands of people a dynamic schedule. So can be easy scheduled. It can be easily canceled, very simple, very easy. Either way, the physician or the provider and the patients can schedule or cancel at any time, and they are free to do that. And then we have focused electronic health records, so it is not lengthy health records. And we made it a very easy billing as bundled billing or cash billing. So those are the new 5 new pillars that we build the system on it. So the patient can click again with anyone. They can select their own provider by themselves. And based on the time and the location or any other criteria, years of experience, speciality, they can pick their providers. And then the provider will provide his or her time, which is available. Could be in the morning, could be in the evening, could be in the weekend, could be any time. And the computer will divide it into 15 minutes slots. And then patients can click simply on the phone and click and get that appointment. They can see who are available, what times they are available, so they can click in. But patient and provider has a chance to cancel at any time without any limitations. And we were able to reach patients that were not able to reach before. Again, this is back in 2019. So this patient has more than 10 medical problems. She has double amputation. She cannot come to the practice on a regular basis, and that's why she was not controlled. Her A1C was very high, 9.4 at the beginning. Few months in the program, and the A1C is down to 7.1, and then finally it is 6.1. And patients reduce their medication, her medication significantly, and is using less and less insulin. So basically, to make it short, because there is a lot of details, but you can see it in the article about diabetes care reinvented. What we changed from classic model to Joslin model, and instead of longer visits of 30 minutes, it is shorter visits, can be 5, can be 10. And we found that the average time in our pilot is around 11 minutes. So visits can be conducted in very short period of time. Infrequent visits in the classic model, we see our patients every 3 months or 6 months. Now we are seeing them every week or every 2 weeks or every 4 weeks. It depends on when the patients would like to be seen. So frequent visits, and we found the average is like 4 per month at the beginning, and then started to be much lower. And instead of rigid schedule, this is now very flexible two-way schedule. Patient at home or at work. So if the schedule had been canceled, there is no big deal. The visit is just 15 minutes if the physician canceled. And we found that, very interestingly, only 25% were canceled by patients or by physician, mostly by provider. And then this is all high overhead cost. Of course, again, this model is a very low overhead cost. There is no person in between to schedule appointment or to make all the arrangement for the visits. Again, people are having travel time and cost for patient now. Of course, there is less travel time, and the cost is significantly lower. Even the co-payments, even the insurance payments, and all those stuff are less cost because there is less manpower used for that process. And I believe a lot of you had been doing it through the COVID and get that experience. But mind that we created that model before the COVID epidemic. Again, the classic model is not suitable for some patients. The virtual model is suitable for most patients, except if someone is struggling to do technology. Moving to mobile health, and mobile health is very interesting because you can text and people can receive the texts immediately. They are using a smartphone, which is in your pocket or in your hand most of the day, or all the day except during sleep. And then you can send the blood glucose data in a very easy way, either from BGM or from CGM, which is widely used now in both type 1 and type 2 diabetes. But the most interesting, how we can implement a digital lifestyle intervention for diabetes. And as you know, there are several thousand companies are doing it now, and especially do it in the diabetes prevention program because there is reimbursement there. So they work hand in hand with healthcare systems and insurance companies to deliver diabetes prevention program to their patients. But for obesity and for diabetes, they are still crowning in that area, but the future will tell us more and more. But interestingly, every time intensive lifestyle intervention is done through digital intervention, actually the results are much better. A1C is lower by 0.6 after 12 weeks. And there are many meta-analyses now, and I will show you some of them showing big benefit. So to design an effective weight management program, my colleagues mentioned diabetes prevention program. They mentioned the Look Ahead study, and also they mentioned Y-Weight program, which was created at Joslin Diabetes Center back in 2005. The major difference is that Y-Weight is a real-world clinical practice weight management program designed specifically for people with diabetes. Look Ahead and Diabetes Prevention Program are clinical, multi-center clinical trial. And I was lucky to be investigator in both trials and also helping in founding Y-Weight program. One of the major challenge is how to educate people about exercise. As Jackie mentioned earlier, this is not steps that people will do in a simple way. This is actually, I will consider just increasing physical activity, but not real exercise that we need for our patient, not only for weight loss, but also for weight maintenance. So we need stretching exercise, we need aerobic exercise, and we need strength exercise, as Jackie mentioned. And those should be implemented. The problem is that how you can educate people on strength exercise without injuring themselves. And mind that you are working with weights or with a stretch band and you are moving around joints and people are overweight and obese. So without personal trainer, you cannot do it in a very efficient way. Also, stretching exercise is very difficult to implement. But technology is giving us a lot of ideas. So Jackie was doing here the stretching exercise, which I believe one of the best exercises that can be done was a stretch band. You can do many strength exercises. You can do also some stretching as well. But as I mentioned, technology is giving us a lot of opportunity. So if we get an avatar, and that avatar will show you how you can do all those activities. And we remember all those fantastic movies that Avatar had been used in those movies. And the technology is advancing to a degree of the fine details. You may remember that the movie of the Benjamin Button movie. And in reality, Brad Pitt was not in the movie. It is an avatar for the entire movie doing it. So taking that scenario and take the activity and put it on an avatar and let the avatar demonstrate the exercises. So you put sensors on the body of the exercise physiologist everywhere. The exercise physiologist is doing the activity and the avatar is showing how this activity is done by software engineers. So now, interestingly, you can now get any evidence-based structured clinical program like Y-Weight, and you can use now the machine learning technology, which is booming now, and artificial intelligence. And then adherence is important. So one way to improve adherence is to put it in lovely way in animation or in gaming, and gaming had been showing very good success and good adherence. People are using cell phone gaming for long time. And then give them the coaching, which is important because as you hear, there is must be some accountability. And Aaron mentioned this as very important for behavior change. And then you can now coach people. Maybe you can text them or you can virtually interact with them. This is much better just that you would send an email or you do it through electronic health record. Now you are in direct contact with your patients, similar to phone call. And now putting people in game. And you can put them in several games every day. You put them in a different scenario of gaming, make them excited, give them rewards when they do very good achievement. But the most interesting now with artificial intelligence and with machine learning technology, you can ask people about their meals, what they like, what they don't like, their nutrition, their clinical situation, what they have. If they have hip pain or neck pain, this can be easily eliminated on the exercises to make it safe and effective. And then you can customize also the cognitive behavior support based on the major problem, large portion or skipping meals or binge eating or excessive snacking or whatsoever. So Giving them gaming, giving them tasks, showing them exercise, educate them and reward them. I think this is a successful source of digital intervention now. And many companies now started to develop them. Even they are sending people to their home all the tools that they will need: scale, stretching band, measuring cups, kitchen scale, and Fitbit or fitness trackers. Not only that, this information can be transferred to electronic health record in a very easy and very simple way. So people can see immediately how the weight loss progress, what the minutes of exercise that they are doing, are they achieving the target? So here is a target, 1,500 calories. The weight loss is -8. They are on target 117% of time. This is the calories that they are eating. Here is the exercise. Here is a compliance rate. Not only that, it can even automatically, through artificial intelligence, create a card for the patient, showing them what they are doing, how they can, what is missing, what they need to be done. It can even tell the provider what to tell your patients, even if that provider doesn't have all that knowledge. So you can print a plan, you can print a scorecard, you give it to your patients. You can show them before and after. But many technology are evolving and they are very interesting. So here is an example of technology, what's called a smart kitchen. So imagine on the refrigerator, you have all the data about your meal plan for the day, cooking instruction, all advice, frequent asking questions, but that data is also sent to a screen, to the stove, and even they are sending it now to even dishwasher. You can put a small robot in the kitchen, and the small robot is talking to you, giving you all the information that you will need. It has a face recognition, it has full meal plan, and it has two-way interaction. Several companies now in the US and in Japan and in Korea in South Korea are working on developing all this stuff. We have tested several of them, and they are working in a very nice way. There is also a capability right now by spectroscopy to look to the meal, and you can get the nutrition facts from that meal. You don't need all this hassle of calculating carbs or calculating amount of protein or fat. You can just point to the meal and you can get all the nutrition facts. So that can make life way easier. You just look to the meal, you will know what is exactly in that meal. You can create a healthy work place. You can make competition between different departments at work, accounting, finance, marketing, management, and you can see the amount of exercise every department is doing, the amount of calories that they are consuming. You can reward people who are doing very well, or a group. You may have a teamwork. Again, this is creating a much better and healthy working atmosphere. Virtual reality. This is, again, looking to the future. You can wear the virtual reality glasses, and you can be in the kitchen with a chef explaining for you what to do. You can see people exercising, and you can do some activity, but be careful in the space that you are in. But there is a lot of opportunity. There is a big video production now going on in that scenario. And then robotic. This is the future now. A robot will salute you and give you all the advice and walk in the dining area or in the workplace and interact with people in a very nice way. You can ask the robot, and the robot will tell you what you need to do. We are using Siri now. We are using many, but the robot is designed specifically for weight management. So clinical trial that had been done so far on short-term, long-term, and short-term weight loss and diabetes improvement through digital intervention, showing with no doubt big benefit. And that's encouraging people to be less dependent on face-to-face and do more on the digital atmosphere so you can reach more and more people. So in the article, I visioned with Sahar how we can create a whole ecosystem. And the whole ecosystem, you communicate with people through their smartphone. So in that scenario, you can do food logging in a very nice way. And as Aaron mentioned, you learn from your logbook. This is very good biofeedback data. By artificial intelligence, you can analyze this logbook and you can give advice. Some companies now are giving a rating, like Good Measure and Levels. They are giving you rating for the meal or for the diet, so you can get that nice information. You can communicate with the pharmacy. You can send the prescription. You can get feedback from the pharmacy on the renewal, and also when to take your medications and the dose and so on. You can make the telehealth appointment, as I mentioned, and you communicate with patient. You can have diabetes forum and group education. This is very easy and simple, similar to what we are doing right now. You can do remote monitoring of your patients through communication with diabetes team. In US, it is reimbursable. So if you look to the CGM and you interpret the CGM, you will get paid for that action. You can track weight and you can track exercise in a very efficient way without missing any of the data. There are many ways. You can have a fitness tracker, or you can have even the cell phone with you all the time. And as I mentioned, it is valuable for people with diabetes because there is a lot of things that can be done. We have what's called group intervention, that you can have the data for everyone and you can pick who are not testing or the blood glucose is high. You can identify easily high-risk individuals and you can create an interaction with them through telehealth. And of course, this is a very nice source of education because everything can be recorded and can be posted. So in the future, I don't like to scare you, but this is how it will be, that in every step during your way, there will be an interaction going on, especially when G5 will be available. So you will connect with a grocery store. You can get your meals and food delivered to your home, pharmacy, sporting places, vitamin and supplement store, doctor's appointment. Everywhere you go, you will be connected, and this will also collect very, very nice data and help decision to be done. So the future is telling us there is no need for the doctor to be always in office and the patient to be in your clinic. I personally believe that the best place to deliver healthcare is where the patient is, whether at beach or at home or the hospital or wherever. And the doctor can be in Hawaii or can be in India and can communicate still with his or her patients in a very efficient way, like what we are doing right now. So take home message: improvement in A1C and body weight through telehealth and mobile health is now documented, not only from randomized clinical trial, but also supported by several meta-analyses on long and short term. Jocelyn Home model, innovative, scalable model for diabetes care using digital health technology. Education and support can be achieved through remote coaching and tele monitoring, which I explained, and it is very cost effective. Telemedicine is much cheaper, and mobile health is also makes it easy and simple. Even in the United States, some phone companies now are offering digital health for free and internet connection for free for places that or for programs that will use digital health. And finally, I think accessible diabetes and obesity care is conducted where patients live or work. This is a big change from what we are doing right now. I think I am on the minute. I saved 53 seconds. So I would like to thank you so much for good listening.